We've just completed our first full year. We've done 100 patients this year, and one of the key aspects is moving away from narcotics or opioids into a multimodal pain management. So why are so many people here tonight? Probably three reasons. Number one, there's a huge growing demand for knee replacements, and I'll show you the numbers in a minute. Number two, if anybody needs surgery, they want to stay out of a hospital if at all possible, or if you have to go to a hospital, you want to be in the hospital for the shortest amount of time. And number three, you want a rapid recovery and accelerated rehab. And I'm going to tell you, I don't have any magic here. This isn't any magic biology. We can't change Mother Nature. It's still surgery. There's still incisions. There's still healing. But it's absolutely amazing what this multimodal pain approach has done for knee replacements. And I'll go over the history of where we've come from. But let me introduce a few knees and a few patients who have been kind enough to come here tonight. One is Barb, one of my neighbors, and you can see on your far left, that's her x-ray. She was bone on this side. She put up with this for a long time. Barb is an avid exerciser, and believe me, she would not entertain surgery if she didn't need it. But even though Barb is Medicare eligible, she was fortunate enough not to be covered by the Medicare insurance program. So she was eligible, and I'll tell you why a little later, with our outpatient program. So Barb came in that day. We did surgery. It took us probably about a half an hour, and she was home 2 hours later. And Barb is up front, so she could answer. So stand up, Barb, for a second. So Barb will, Barb. Yeah, Barb and Mark, or Dave. And Dave, was Kim here? Oh, there's Kim. Kim, how you doing? So good. So Kim, Dave, and Barb will answer any questions that you want later on. I think it's important to really get it from those patients and hear their results. Ironically, I was going home that night, and I happened to drive by Barb's house, and I decided to stop in and just check on her. So I knocked on the door, and I heard her husband slowly walking toward the door to open it. And to my surprise, it was Barb that opened the door. No cane, no walker, no crutches. And I said, "Where's Mike?" And she goes, "He's downstairs getting a glass of bourbon." I figured I'd answer the door. So Barb did pretty good that night. So here's Kim from Lehighton, and those are her two x-rays, and you don't have to be a radiologist to see on her normal side, she has a 1/4 inch of space in here. On the involved side, she's down to bone on bone. And again, an hour later, here's Kim's x-ray with two components of the knee. I don't like to call it a knee replacement. We call it a knee resurfacing. It's more, we should change the word. Knee replacements have been around for 60 years. It conjures up this image that we take your knee out, we throw it away, and we give you a new knee, which is nothing like we do today. It's more like a dental procedure where we just replace the cartilage and we put a crown on the top and we put a crown on the bottom. And then Dave happened to come in today. And Dave is 3 months, and this is what, 3 or 4 months? 4 months, Dave? 6 months. 6 months. Yeah, so this is what we like. We come in at 3 to 6 months. There's Dave's x-ray on the left. He's near bone on bone, and here's his x-ray about an hour later. So at 6 months, and Dave could tell you in his own words, he went home that day. He wasn't in the hospital, so you avoid all the unpleasantries of a hospital, even though our hospital is wonderful. If you could stay out of a hospital, stay out of it. I always tell people, if you want to avoid an airplane crash, how do you do it? You stay out of the airplane, right? So you stay out of that. So anyway, he came in today, and he was kind enough to come over from Easton and share his story with us a little later. Dan Hilt couldn't come. Dan was a revision. I did him 12 years ago on the far left. He had a partial knee replacement, and if we get 10 years out of those, we're pretty happy. He got 12 or 13 years. He's a contractor. He puts roofs on, but he couldn't make it tonight because he's refereeing a track meet. So before I go into the details, I have to say that there's many components to success of this rapid recovery outpatient total joint arthroplasty. But from this, there's a patient component, there's an institutional component, but there's a surgical component. And on my side, it's the team. And I truly have a class 1 team. And anybody that's been our patient from left to right can see RJ Ritchie, Melissa, Jamie, and Tom Witter. And that's our team of PAs and extenders that we just do knees on my team so they know every patient pre-op, post-op. Tom and RJ are in the OR with me. So we don't have residents or fellows that rotate every July or every 6 months. So we have a very, very consistent team that has done tens of thousand procedures with us. So this is part of our formula for success. And I could give you a lot of graphs and words, but I think sometimes, I don't know if the, let me just play a few quick videos. This is a 35-year-old Division I athlete, had 7 surgeries. At 35, her knee was worn out. She needed a knee replacement. I did it as an outpatient. She went home an hour later. I didn't do it at Coordinated Health. I did it at another regional hospital, and I got called by the head of their orthopedic department, and he's very nice, but he said, I heard you did outpatient total knees, and I've done a couple at that institution, and he said, I'd really appreciate you not doing that anymore. And I said, sure. I said, why? And he said, well, I couldn't find any level 1 studies that compare that to inpatient surgery. And I said, well, level 1 studies of this nature will take 10 years, before the long-term studies come out. I said, did you know that it saves you money if I send them home because you get paid by the insurance company the same amount whether they're there for an hour or 2 hours or 2 days? And I said, the hospital complications will be less because there will be none. She'll be home in 2 hours. And so, but I said, I'll be happy not to do that. So they didn't want me to do it at that hospital. So this is the traditional way of doing knee surgery. What they would prefer is this patient that was healthy, that was up and walking, did a set of steps an hour later. They would rather just stay in the hospital that didn't need to be in the hospital, have an IV in, and stay 1 to 2 nights, not for medical reasons, but just because that's the traditional thinking, which is hard to change in medicine. And I'll go over that. I did this gentleman last week, and most of these people, I make them walk and pee and get out of the chair, and not at the same time. And he has a big Band-Aid on his knee. It's on the inside, it's not in the middle, and that's because he had an incision on the other side. But he refused to use a walker, a cane, or crutches and going home. So, I mean, it's absolutely amazing to see some of these patients. Now, we put everybody on this rapid recovery program, so I don't want to misinform people and think that this is just for outpatient. Whether you go home or not, you're on the same multimodal pain approach, and I will go over that, whether you're inpatient or outpatient, for whatever reason, insurance, home situation, you're out of the geographic area, you can't go home, you will be up, out of bed, walking an hour later in the hospital. So we treat you just like you're home and on a rapid recovery program. I try to stay away from doing both knees anymore. Oh, back up a little bit. I don't do both knees just because of the higher complication rate. This guy's a skydiver, 69-year-old skydiver. So he wanted both knees done so he could skydive, and at 3 months, he wanted to prove to me that he could land when he jumps out of the plane. So this is him with both knees jump, and then he says he does the Irish jig, and I said, all right, go skydiving if you want. I don't recommend it, I said, but if you don't want to die skydiving, you don't jump out of a plane. But anyway, this was guys. So these, I mean, you just look at these, this is another one of my, Lehighton patients. That's Dave's Deli over in Beth. We just have a bunch of them. But it gives you a feel of what you can do after this rapid recovery. And this is with no narcotics. Narcotics are the bane of our existence. I don't know if anybody watched CNN News this morning, but there was a big thing on narcotic pain. I was just driving to work today, and I thought it was pertinent to this talk. But I think it was Sanjay Gupta had a special on narcotic pain medicine. It just became the #1 cause of unavoidable deaths in this country. Once every 19 minutes, somebody dies of a narcotic overdose. And a lot of those are prescription drugs that are at home that are just prescribed nilly-willy, by our providers around the country. So it exceeds the number of people that die in a car accident. So this is the bane of our existence. Anything we could do to get rid of narcotics. And I'll tell you how we do that. My sister gave me this book at Christmas, and I was just reading it on a plane trip recently. It was very pertinent to what we're talking about. It's about conformity and nonconformity, and how people that change the world are almost always nonconformists. Conformists are very successful. They follow the status quo. They get things done. And I was thinking, in medicine, almost everything we do to get to where we are in medicine, you have to be a conformist. We are trained to be conformists. We're trained in high school to take tests and SATs and pre-med in college and basic science and MedCats. And then in medical school, we do the same thing for 2 years. Then we do rotations. We have to conform. We want good evaluations. You have to follow medical guidelines. And by the time we're in our residency, you have 5 or 6 years of residency training to do that. It's like military. You're just trained to be conformist. So it's very, very hard to step out of that line and think on your own. And you're actually criticized or vilified in medicine if you do that. And this is one of those things that, that we can be criticized for. But we don't enter this willy-nilly. I've been doing this for 20 years, believe it or not. So how is this something new if we're doing a rapid recovery program? But we've been doing outpatient partial knee replacements for 20 years. So for us, it was not a big step to go into the total knee world. One of the big steps is changing the whole culture and getting everybody on board, setting up a patient engagement, a patient educational program. But as I was thinking of conformity over my career and 27 years of doing this, I wrote a list of all the things that were controversial in my career that we were vilified for. And I'll just highlight a few of these, but I highlighted them in red. One of them was, the open fixation of clavicle fractures. We took care of the velodrome for years. Cyclists would fall down, break their clavicle, and they wanted it plated. We'd put a plate on their clavicle. We'd get them back on the bike in a week. But this was not the standard of care in orthopedics. Every other bone in the body, if you break it, we rot it or we fix it or we screw it. But clavicles, they all did well. You put them in a sling and they did well. But if you drill down on the data, they didn't do well. 15 to 30% of them did not do well. And at one of the large trauma centers, we were vilified every time we fixed a clavicle. What are they doing? They're operating too much. And 20 years later, in 2009, it became the standard of care. And in the meantime, it's one of the few things that we do besides knee surgery on my team. We invented a clavicle plate that is now one of the lowest profile, best plates on the market. But we were vilified. And here's a list of 20 things that we did in our career. I'll touch base on one more because I don't want to spend the whole time. I could do a whole nother show on this. But one of them was replacing dangerous heparin or Coumadin for aspirin after joint replacements. Everybody for years was placed on rat poison, which is Coumadin, to stop blood clots. But the side effect was bleeding. And so about 7 years ago, we decided to look at the literature. We didn't come up with this on our own, and it looked like in young, healthy people without a history of blood clot, if you moved them, put compression boots, and put them on aspirin, they did as good or better than Coumadin without the bleeding side effects. I did this again at one of the institutions. I had to give a grand rounds at that hospital to rationalize and explain why the medical literature supports that. Now, you know what the standard of care is after total knees for a DVT prophylaxis? Aspirin. 99% of all our patients, unless they have a history, get aspirin. They would go to Good Shepherd. They would stop the aspirin. They'd put them back on the Coumadin just because that's conformity. They can't think out of the box. They can't look at that. So this is what we fight, in medicine. And I mean, we were called, snake oil salesmen in 2004 for fish oil. We were the first orthopedic group, along with the Rothman Institute, to recommend fish oil for its anti-inflammatory effect. You know what we did? We just completed a multi-center study with Jefferson showing the value of the fish oil in decreasing inflammation in arthritic knees. So 10 years ago, we were laughed at. Now, I mean, everybody takes fish oil. It decreases your risk of complications after surgery. But again, 10 years ago, we were vilified for these sort of things. So it goes back to that conformity, nonconformity. And we're not the first ones to do things, you know. Very rarely is there an original idea, but you take somebody's idea and you build on it. And just like this outpatient arthroplasty, last year there was about 20,000 of these done around the country. That's a big number, but it's a small percentage of maybe 700,000 done around the country. So in the region, nobody else is doing that, because you can't just say, well, I'm going to do an outpatient total joint, because behind the scenes it's like Disney. It takes an unbelievable infrastructure to get all of this set up and do it safely. And I'm going to show you the results on our first 100 patients, you know, in a little bit. So the real scope of the problem is this. There's over 1 million total joints done per year, and this was a couple years ago. Historically, it was managed poorly with pain. Everybody got narcotics, and narcotics just work in the brain, and the side effects are tremendous. And the greatest growth in joint replacements from a percentage standpoint is going to be between 40 and 65 years of age. And that's a group of people that's relatively healthy. They don't want to be in the hospital. And even our Medicare group, if they're healthy, they shouldn't be in the hospital, but the rules are going to have to change. The expected growth of outpatient arthroplasty is 3,000% over the next 10 years. So somehow we have to accommodate that. And it's not going to be accommodated in the big, you know, ivory towers. And we have to find cost-effective solution. It's cheaper, and it costs less money. So if it costs less money and it adds value, and people do as well or better without complications, why not? Because who's paying for that? You know who's paying for that in this country is employers. Employers, self-insured employers, they're paying the insurance product. So if we don't do this, the cost won't be saved. And if it's not the employers, who is it? It's you. If you're buying your own insurance, you know, the insurance companies don't assume this increased cost. You do. They pass it on to the consumer. So, you know, this is the biggest price burden for Medicare, total joint arthroplasty, is why it's in the target of the government. And here we have a method to save money, but, you know, our Medicare and our government insurance program just drags their feet. It's just very, very slow. Why do they approve an outpatient partial knee replacement, which takes us no more time? It actually takes us longer to do a partial knee replacement than a whole knee replacement, because we're doing it through a smaller incision. It's a little tighter. Patients in the OR touch a few minutes longer, little longer anesthesia, but yet we can't do a total joint for a Medicare patient as an outpatient as of 2016. And look at the natural history of this. Talk about conformity. ACL reconstructions used to be in the hospital for 2 or 3 days. Rotator cuff spine surgery, partial knees. Remember cholecystectomies, your gallbladder, you had a big incision in your stomach, you were in the hospital when I was an intern for 7 days. Appendectomies, hysterectomies, these are all done as an outpatient. So, you know, the natural progression will be to do a larger percentage. It will never be all of them, because you're still going to have a huge Medicare population, 60 to 90 years old, that's going to need hospital services. They've had heart bypass surgery, they've got asthma, they've got some liver disorders, kidney disorders. I mean, we do knee replacements on people on dialysis. So we are going to need those tertiary care centers, but a larger percentage, they're estimating about 50% of total joint arthroplasty can be done as an outpatient, you know, in the future. So the argument is, I want it done in the hospital because it's safer. Very few people say that. You know, most people say, if I can stay out of the hospital, I'll stay out of the hospital. Just ask, you know, Barb and Kim and Dave. But here's the real data. We just talked about, you know, narcotic overdose as the highest percentage of unavoidable deaths in the country. Look at this. The third leading cause of death are medical errors in hospital. 400,000, almost 500,000 a year. And like I said, we have a wonderful hospital. We have the lowest infection rate in the state, 0.02%. But even if you could stay out of our hospitals, stay out of our hospitals. I'll tell you an interesting story about pain. I'm part of this national outpatient program where I'm on the faculty, and they did this study where they treated the people in the hospital and the people going home the same way, the same pain protocols, the same preemptive medication that I'll go over that we start 2 days ahead of time, how we avoid narcotics. And the people that went home versus the people that went in the hospital had a 30% lower reported incidence of pain, 30% lower. Nothing different, no magic, other than they just went home. And nobody knows why that is. Is it just the fact that they were being observed? But they go home and they're normal. They expect, they're in their clothes, they're not in their pajamas, they're not laying in bed with the nurse coming in saying, is your pain 5 out of 10, 6 out of 10, or 7 out of 10? They're going, well, I don't have any pain, but I guess I should have pain. I'm in the hospital, I have an IV in, and you know, they gave me a spinal, so now I have a Foley in because I can't pee. And you know, I mean, but I could just, you know, I could talk for hours on the number of patients that said my knee is great, but I'm going to the urologist because I had a traumatic catheterization. They put a catheter in, and now I'm still having problems. And you go, you know, how can we avoid these? And it's really the right patient with the right medical profile for the right length of stay. That's what this rapid recovery is about. It's not doing it all as an outpatient, but it's just profiling the patient for the right amount of minimal stay, you know, in a hospital. So here's the results of our first 100 patients. Not to bore you with graphs, but from a symptom standpoint, the bottom purple line is our outpatients. And really what I wanted to see is they weren't any worse. So it basically parallels that, but from a symptom standpoint, it's even, you know, they have a touch lower symptoms, you know, at a year. From a pain profile, the same thing. Their pain parallels exactly our inpatients, but you know, but if anything, it's just a touch better. Is that patient selection? Maybe they're younger, more active, who knows? But anyway, it looks like what you want to show is you're not hurting people. They're not, you know, they're not having, we had no medical readmissions on 100 patients. So that means we're selecting them correctly. And we're not guessing, we have a patient tool. And their function is the same or a touch better at a year. So that's pretty exciting. First 100 patients in our first year. But again, we've been doing this for 20 years with outpatient partial knees. All we did was put a team together. We became part of a national program so that we compared our results to, you know, other surgeons doing this. And again, coordinated health, you know, for a small hospital compared to regional hospitals, we do more joint replacements than some of the big hospitals in the area, and volume matters. We have great scores on all the metrics from the National Association. So our patients, you know, in general, we have a very sophisticated tool. So if you come to our joint camp that Melissa runs, you know, we go through this whole test that you have to take, and you get a score. And if you score between 30 and 35, you fit our criteria to be an outpatient total joint arthroplasty candidate, and you have virtually 100% chance of going through that successfully. So we have a margin of error that we've built into that. If you end up between 25 and 30, then you can stay 23 hours in the hospital. And then if you're below 25, then you're one of those patients that maybe should be in the hospital 2 to 3 days and even go to rehab. So we don't put this through guesswork anymore. We have metrics, you know, that we measure. I went over this. You know, the unicompartment knee is designated as an outpatient procedure. We can do that, but you can't do a total knee as an outpatient yet. But again, once I showed you the finances, Medicare is going broke. So this is one of the areas that they have to save, you know, some money in. So, you know, our surgical techniques have all evolved. People say, you know, how has the prosthesis evolved? I'll tell you, the prostheses have sort of almost hit a limit. Some of the mechanical properties go 30 years now, so it's going to be, you know, we will tweak those, but the biggest incremental improvements is our soft tissue approach, how we align it, how we match it to your anatomy, minimizing the incision, minimizing the surgery. You know, you don't want to have a 2 or 3 hour operation. We have protocols for everything. We just don't, you know, say we're going to have minimal blood loss. We have a whole protocol that limits blood loss according to your preoperative hemoglobin. If you're low, we have you on either medication or iron. Intraoperatively, we have several tools of coagulation. We have new chemicals called tranexamic acid that we give IV and intraarticular that has almost eliminated the need for transfusions. So we have minimally invasive techniques. Now, it's not the size of the incision, but it's how you treat the tissue underneath. So I always say you have to make an incision to do a perfect job. Years ago, people try to make this little 2-inch incision, and the failure rate at 3 years was too high because they couldn't see what they were doing. They're putting cement in there. So simple things like not averting the patella, not cutting any tendons, being very gentle with the tissue, not dislocating the tibia. So there's a whole lot. If you're kind to the tissues, there's not that much pain. If you're not kind to the tissues, it generates inflammatory mediators. People are on PCA pumps, they're on morphine, they need opioids. 60% of all hospital complications can be directly related to the narcotics that you're given in the hospital. So, if you can just tell our patients in the hospital, even our Medicare patients that used to have to stay 2 days, we now get them home almost religiously in 23 hours. They have 1 night stay because they're up walking around and they don't need to be there 5 days. If they're there 5 days, they've got swelling, they have a drain in, they have that old CPM machine. I mean, these were some other conformities that we stopped doing years ago that some hospitals still use. But when you look at the data, there's no data on some of these things. CPM machines don't improve results. People say, aren't you going to be on that machine that moves you back and forth? We go, no. The data shows there's no difference. Not only that, but they can hurt you. Some people get decubitus ulcers on them. Some people get foot drops because their nerve is on them. So, so even our inpatients, and I'll show you the curve, our whole paradigm has shifted to the left. So our average length of stay is 1 day, average. That means some people go home in 2 hours, the average is 1 day, and then we still have our people that stay 2 days. But our average length of stay now is down to 1 day.